friends, doctors, and those who are hearing me in this audio conference in this COVID time. I have to talk to you today about the latest update in hypertension. Hypertension is a slow and silent killer, as all of you know. And the most interesting fact that World Health Organization has recently assessed that the 63% deaths in non-communicable diseases in India is contributed by out of that around 27% is cardiovascular disease, and of that around 49 to 69% age group people suffer from mostly hypertension related cardiovascular problems. And today hypertension is the most causative factor or contributing factor for cardiovascular disease. Hypertension is poorly controlled due to lack of awareness about hypertension among the patients. And it is today the job of the physicians to alert them about the proper treatment, proper control, and proper adhesiveness to the drugs, along with the change in the lifestyle. WHO has interestingly assessed the situation in India that in last 30 years, the incidence of BP has increased in men from 29 to 38%, means more than 1/3 of the persons are suffering from hypertension in men, and around 28% to 32% in women. This is the increase that we have gained in India in last 30 years. Interestingly, about the awareness that I am having a hypertension is known to only 51% of men and 41% of women. And regarding the treatment, there is no treatment in those patients more than 62%, and in women more than 53%. The treatment that is sincerely taken among these patients is 1 out of 5 in men and 1 out of 4 in female. So in such a situation, the prevalence that has increased in India, which is reported recently by World Health Organization in Lancet 2021, very recently, and the International Society of Hypertension has recently reviewed in 2020 about the global hypertension practice guidelines. All of you should see that, though the American Heart Association has fixed the blood pressure that 130 to 140 by 80 to 90 diastolic is stage 1 hypertension. International Society has reviewed in latest is more than 140 to 160 by 80 to 90 is grade 1 hypertension, and beyond 160 is stage 2 hypertension. The inclusion of optimal and essential treatment paradigms attempts to address the issue that the resources in a poor setting and the optimal care refers to evidence-based standards of care, and where as essential standards refer to minimum standards of care to allow the specification of essential standards of care or low research settings. India is interestingly low research setting, in that at least we should try to achieve a blood pressure of 140 by 80 in patients with hypertension, and particularly in diabetes, we should see that the control of hypertension should be less than 130 by 80. ACC and ASC guidelines released a scientific statement in 2021 offering a new guideline for the management of stage 1 hypertension among patients with low atherosclerotic cardiovascular disease, and among low-risk adults, no ASCVD or 10-year CVD risk less than 10% with stage 1 hypertension blood pressure, that is blood pressure between 130 to 139 and 80 to 89 diastolic. The management starts with non-pharmacologic therapy to start with. If the blood pressure remains uncontrolled at 3rd to 6th month, consider starting pharmacologic therapy. This is because of the low setting. It is a new review by AHA-ACC guidelines recently published in Hypertension 2021. And the respiratory distress syndrome, that is potentially fatal condition involving lung damage, and experts often associate it with severe COVID-19. A recent study which appears in the Journal of American College of Cardiology reports that metoprolol can reduce lung inflammation. Metoprolol can reduce lung inflammation and improve the respiratory function in people with COVID-19 induced ARDS. This is recently published in September in JACC 2021. Another interesting thing is lowering blood pressure targets down to 110 or less than 130. It can substantially reduce the severe adverse events in STEP randomized trial, confirming the results of SPRINT trial, in which it was only systolic study for an older patient. In an elderly Chinese population, this STEP trial was conducted. Among some 8,500 patients with 60 to 80 years in China, with the intensive target trimmed down 26% of the cardiovascular events. Finding now that the major trial supporting the lower target unite the guidelines which was given by US basing on the SPRINT trial earlier. This was published by Zhang et al. With New England Medicine 2021, very recent. With regard to the prognostic value of ambulatory blood pressure monitoring and the nighttime blood pressure, in 2018 European guidelines on management of arterial hypertension recommends that the diagnosis of hypertension should not only depend on the office blood pressure, which is our usual practice, but also the out-of-office measurement is also important, like the home blood pressure monitoring and the ambulatory blood pressure monitoring, in which the 24 hours record can be taken and the night blood pressure measurements can be also taken. The night BP measurements were associated with increased risk of mortality and a composite CV outcome. Thus, they may be considered as important relevant measurements for estimating the CV risk. For every 20 systolic and 10 diastolic millimeter of mercury increment of blood pressure measured at night, the risk of mortality increased by 23% and the risk of cardiovascular event by 36%, which is very significant. So the non-dippers in the night in ambulatory BP has to be addressed even if their blood pressure in the office is normal or apparently controlled. Most patients with hypertension require lifelong medical therapy to achieve optimal blood pressure control and the effect of hypertension-related trauma to the body. In 2018, European guidelines equally recommend 5 classes of antihypertensive drugs. All of you are aware of that. But most important thing is considering high adherence of treatment. The importance of combination treatment is particularly highlighted to improve the adherence to therapy and blood pressure control. Therefore, in 2018, European guidelines recommend specially in context of lower blood pressure targets to start antihypertensive therapy with initial dual fixed dose combination of ACEI and CCB or a diuretic. ACEI, ARB plus a CCB or a diuretic. That should be the initial starting combination therapy for the hypertension when we start the treatment. Since the early July 2018, the products containing valsartan have been recalled worldwide. The reason is the detection of a known carcinogen, namely the NDAM or N-nitroso dimethylamine, which can be found in the candesatran, irbesartan, losartan, olmesartan, and valsartan. NDMA has been classified by WHO, International Agency for Research on Cancer, to be carcinogenic in humans. If 1 lakh of patients would have received NDMA contaminated valsartan from Zhenghuai manufacturing site where the highest level of contaminants were found every day for 6 years in the highest dose, it would result in 22 additional liver cancers over the lifetime of these patients. The presence of NDMA in these drugs would lead to 8 additional cancer cases in 1 lakh patients if they had been taken the highest daily dose over 4 years. Valsartan recall accompanied by a significant increase in the rate of emergency department visits of 6% plus. Another interesting thing that has come, when should you administer the drug of hypertension was studied by HYGEA study, represent the largest study that tested the nighttime hypertension treatment, or the intake of hypertensive drugs should be in the morning or in the night. In this trial, the chronotherapy was associated with a significant reduction in endpoint, including death. The HYGEA chronotherapy trial tested whether the nighttime therapy, in comparison to the usual awakening in the morning hypertensive therapy, exerts a favorable CV risk reduction. The largest study included a total 19,084 hypertensive patients during an average follow-up of 6.3 years. 1,752 participants experienced the primary CV outcome. An ambulatory BP measurement was performed for 48 hours to collect the data on how BP default during sleep. The RR reduction of CV event was significantly improved for nighttime treatment when compared with awakening treatment. So friends, to sum up, this is very interesting observations that has come very recently. You can utilize this information in your clinical practice for treating hypertensive patients. Thank you.